Good day, everyone. My name is Mike Hamilton. I'm Medical Director at ISMP Canada. Welcome to the midwinter edition of the Med Safety Exchange. Thank you for taking time out of your busy day. We know you're all occupied doing some really great work, and we appreciate you being in the audience. As you kind of grab another warm beverage, I'll ask our Brock University student at the Faculty of Education, Larian, to perform our land acknowledgement.
Thank you. We begin with a land acknowledgement for our office in Toronto, and I encourage you to reflect upon where you work and reside. We acknowledge we are hosted on the lands of the Mississaugas of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and Inuit peoples. We are grateful to live, work, and play on this land, and we want to contribute to this implementation of the Truth and Reconciliation Commission's 8 health-related calls to action.
Thank you, Larian. And a reminder that this webinar is a production of ISMP Canada and CMERS. And contributions come from all of our partners and you, the audience. A reminder that this is on the Zoom webinar platform. The audience members are muted, your video is disabled, and the presentation part of this webinar is being recorded and will be available on our website in a couple weeks or so. There are a few ways to make comments or to ask questions from the Zoom toolbar, which is typically at the bottom or top of your screen. Use the chat panel. That's open. You can introduce yourself and tell us where you're from. You can make comments, ask questions via the chat panel, and all these chat entries are visible to the audience. If you do select the Q&A tool, there's a secondary window that opens up and you have the option to submit anonymously. We will try to get to as many questions as we can. There may be some we just don't have time for. And there's an evaluation poll at the end of your session, so please help us get better by providing feedback. And we have a terrific webinar plan today. We have lots of great content to get through. First off, we'll welcome our partners at Patients for Patient Safety Canada to remind us that patients and families are the most important resource in advancing safer care. And we'll hear from Healthcare Excellence Canada about a project happening in Quebec addressing a real medication safety challenge in balancing the benefits and risks of an important class of medications. And we'll end by asking our colleagues at Health Canada to update us on the mandatory reporting of medical device incidents and serious adverse drug reactions. So in my 30 odd years in healthcare, we've come some distance in incorporating the patient and family voice in health provision and in initiatives. And it now seems kind of odd if we don't have a patient or caregiver as a partner. But I know we still have a way to go. And I'd like to invite our colleagues at Patients for Patient Safety Canada to tell us more about their organization and ways that patients can be impactful partners.
Thank you very much, Michael, and good morning, good afternoon, everyone. We're so pleased to be able to be part of this and to share our journey as Patients for Patient Safety Canada. We do consider ourselves as partners in shaping care and working with our colleagues. I'm going to start off. I'm the chair of the Board of Directors for Patient Safety Canada, and then I will hand it over to Ioana. Ioana is our executive director. So we consider ourselves a community of volunteers, and exactly what does that mean? Again, I can't advance. Oh, there we go. Wait a minute. There. Oops. Sorry. I was told it was sensitive. Oh dear. All right, so our evolution. Well, 20 years ago, actually in May, a handful of us were invited by PAHO to talk about our patient safety experiences. And so 10 from Canada and other countries came together. That was a long time ago. And since then, of course, we were able to evolve, invite others to join us, and there were many who came forward. Our first meeting in 2006, and then 2007, we actually created Patients for Patient Safety Canada. We were joined under Canadian Patient Safety Institute, who many of you know about, and we actually then had an opportunity to become a program and did a lot of different kinds of things, which we will share with you, because we've grown a lot since then. And in 2024, actually, just last year, January 22nd, it was our anniversary. We incorporated as a not-for-profit. So here we are starting a brand new journey, no longer as patients in a program, but now as a not-for-profit. And growing quite a bit. And we now are Canadian-wide, coast to coast. A lot of members joining, some more active than others, but we are expanding gradually. I'm sorry, I'm having problems advancing the slide. Uh, So each number is a person. And so we always look back to what the numbers tell us. And of course, patient safety is one of those areas that is still not really accurately reported. But even what we do know is that the incidence seems to be climbing. And certainly since 2004, we have been escalating a lot in terms of the numbers. And you can see that 47% of patients and others who have experienced medication safety issues. That's 47%, but the numbers, as I say, are definitely low in terms of the reporting. And certainly we know that we are um, we are a person. We are faced to the number. We are faced to a name. So I'd like to start by actually doing a session poll, and I see it popped up quite early. So here's our questions for you, and I want to just find out, have you ever been involved in a medication safety incident? Yes, no, and not sure. And if you said yes, in what capacity were you involved? Was it a patient, family member, caregiver, a healthcare worker, or manager leader? So can we, is a poll live? I take it is.
Yes, the poll is live, Ken.
Give you a few seconds to respond. Okay. So 79% of you said yes. And that's quite a high number, actually. I was expecting a little bit less than that. But so you are one of those individuals who can identify that, in fact, you've had a patient safety incident or an experience. Most of you identified yourselves as healthcare workers. Some were family members and a few were patients. So thank you for that. So we are on this journey together. And I think that that's an important note to make, that when we look at, and I'm just going to back up a minute, we are on this journey together. I mean, all of us who have had that experience have experienced physical harm. It could be psychological, cultural, financial. Those things are go with us. So they impact us for a long time after the incident. I'm just going to share with you a story of mine because I had a patient safety medication incident that happened to me. 2 years ago, September 11th, I had a hip replacement. Um, Good news is that hip replacement was a total success. When my surgeon came in and asked me what my pain was from 0 to 10, I said 0. After 2 years of waiting, for the hip replacement, it was 0. Amazing. Later, the incident was that the medication specialist, pain medication specialist, came into my room. He asked me the same question. I said I had 0 pain. He said, well, you're going to experience a lot of pain. And so to get ahead of that, we have to give you some medication. And I said, I can't tolerate much. All I can tolerate are like Tylenol, Advil, over the counter. I cannot tolerate opioids. We've tried that. I get very sick. He said, well, I'll give you something and it'll appease the pain and then we'll go from there. Well, 15 minutes after the pain medication was administered intravenously, I went into a tailspin. I became extremely dizzy. I was sweating. My heart was pounding. I could hardly breathe. I felt pressure on my chest. I pressed the button for help. And I said to the nurse, help me, please help me. And all I could remember after that was her calling for a crash cart. And I recall also just going into a bit of a spin. I didn't know where I was at that point, and then I blacked out. I don't recall anything. For 24 hours, I was gone into my unconscious state. When I awoke, my husband was beside me, and the nurse came in and grabbed my hand, and she said, welcome back. And she said, I am so sorry that we did not listen to you. We should not have given you the pain medication we gave you. And my husband said they almost lost me. So that's the story that I'm able to tell. And there are many stories like that, but there are many people who perhaps will not be able to tell their stories. Maybe the family member tells their story. So that's where we're at. And I think that we always say every patient saved as a result of that. That's our vision as Patient Safety Canada. Our mission really is to champion the patient voice to advance safe healthcare. And we'd like to expand that mission now that we have a new strategic plan, because it should include those that we collaborate with, the healthcare providers that are beside us and supporting us. We want to be able to promote safety, to prevent harm, and to learn from our experiences and stories. We want to be able to support those who have experienced harm. And we want to be able to engage and collaborate with you and others with our journeys to talk about improving safety and to make sure that our healthcare system is as safe as it possibly can be. And so now I will turn it over to Iwana to tell us a little bit more about some of the things we've done.
Yes, thank you, Kathy. And hello, everyone. It's so wonderful to be here with you today. You came here because you care about medication safety, and it really breaks my heart to see that so many of you have been involved in a patient safety incident, but maybe that is what unites us to work in partnership to advance patient safety for everyone. So first, let me say a big thank you for everything that you do to keep your patients safe. Our presentation is about engaging patients in patient safety, and I expect that some of you already do so. So please use the chat to share with the rest of the participants, how do you engage patients in medication safety, as I go through the slides and provide a few examples of how Patients for Patient Safety Canada advances medication and patient safety. First, I want to highlight that we are part of a global community. Our story started with the World Health Organization uniting patients that have been harmed with this pledge of partnership, the London Declaration, a pledge to make care as safe as possible, as soon as possible, with patients as partners. We are part of a global network. There are Patients for Patient Safety groups like ours around the world, and I included a few links in the slides. I can also put them in the chat. For those of you who are from other countries, you can look at the WHO website, connect with patients from around the world, and advance safety. We are honored to be designated by Health Canada to be part of the Global Patient Safety Leadership Council. And we are involved in global patient safety summits, Patient Safety Day, and the many campaigns and resources related to medication without harm. And I do want to encourage all of you to have a look at the WHO website for additional resources and support. In addition to being connected with the global community, we're also nurturing a Canadian community. We call it the Alliance for Patient Safety. We have about 16 organizations and individual patient partners who are part of this alliance with the intent of growing this community, learning from each other about problems, ideas, solutions, resources, and so on, and making sure that the lived experiences of patients and families remains at the center of everything we do, because it is a perspective that really can advance safety. We are also working in partnership with ISMP. Oh, I should have mentioned that the Alliance is currently co-chaired by ISMP Canada and Patients for Patient Safety Canada, starting in January 2025. So there's a chance you may hear more about it going forward. Together with our many partners, our goal is to shape policies, practices, and programs. And we do that by being part of the CMERPs. Michael already mentioned that, and you see a visual about the CMERPs on the slides. We support the natural and non-prescription health product project led by Health Canada. We have been involved in shaping and implementing the Vanessa's Law and communicating about it so it spreads. Many education campaigns, frameworks, and guides related to patient safety and beyond. Let me give you a few examples here. The 5 questions to ask is an example of one of the tools that we help create with many partners. And there's several 5 questions to ask, many translated in multiple languages. So please have a look at the ISMP Canada website. Enhanced recovery after surgery, how to speak up and have safety conversations. And we also disseminate the message that patients should be partners in preventing harm, as well as in responding to harm through tools, presentations, articles, our campaigns, and the art gallery. You probably noticed the beautiful pieces of art we selected for today's presentation. So I encourage you to have a look at the art gallery. One project that I would like to highlight for you is what it's called Mutual Healing. It's an innovative project by Patients for Patient Safety Canada, and it's intended to close the bridge between healthcare workers and patients after harm. Many of you said that you experienced an incident. We have a survey and a report from 2019 that showed that only 6.5% of the healthcare workers who experienced an incident received appropriate support from their institution. That breaks my heart even more because everybody should be supported after harm. So the Mutual Healing Project is intended to bring people together to talk about a patient safety incident and close that bridge that leads to healing and more confidence in that care that we will provide and we will receive in the future will be safer. I'll turn it over to Kathy for a few closing comments. I'm going to have a look at the chat and please ask questions. Kathy?
Thank you. So what we'd like to do is to raise questions for you to consider. Think about opportunities. We'd like to raise the bar. When we talk about patients as partners, we want to partner with you. We want to influence what's happening in terms of care to make it safer, building capacity as we go along, and to encourage participation at all levels. So we're open to suggestions and opportunities. We look at the courage and passion that we have as members of Patient Safety Canada. We see the courage and passion in our healthcare providers and leaders, and we want to be able to collaborate with that. So we join the effort, and we actually invite you to consider that. But this is part of that journey. We want to explore a lot of things with you. And I'll just move on quickly here to invite you to become members, to join the board. We're always looking for board members, partners, and supporters. And we planted the seed. We hope that we have grown and evolved. We're still growing and evolving. And so one day, too, we want to be able to say truly that we have been collaborating across Canada with our healthcare partners, health systems, and leaders, no matter where we are. So thanks very much for allowing us to be able to share our journey with you this morning and afternoon.
Thank you both for that terrific presentation. And I really, I've worked with you and your team for many years, and I really encourage everyone to review the materials, review the links, and we'll add the links to our own Med Safety Exchange website in the near future. So please explore them and consider really strongly collaborating, meaningfully collaborating with Patients for Patient Safety Canada and their excellent team. So thank you both. An important component of medication safety is really finding that appropriate balance between the benefits of a medication and the real risk of harm that they often carry. Antipsychotics in particular are often prescribed to persons living with dementia in long-term care, but these medications do have real risks of stroke, death, and other harms. Our speaker today will tell us a very important initiative in Quebec that takes a real careful, considered, and really a complete approach to optimizing the use of antipsychotics in this population. So let me hand over slides to you.
Thank you, Michael, and thank you to Iwana and Kathy for starting us off and really highlighting the importance of patients and patient safety, especially when we're thinking about appropriate medication use in long-term care. And thank you also, Kathy, for sharing your story, because I think it's one that we've also heard through this work that we supported in Quebec from 2017 to 2024. So my name is Tanya McDonald. I'm a director at Healthcare Excellence Canada, and I'm here to tell a little bit of our journey in supporting the appropriate use of antipsychotics in long-term care homes, really across Canada, but with a deeper dive of our work in the province of Quebec. Donc, je vous invite à poser vos questions en anglais et français. Je peux répondre dans les deux langues, so just feel free to submit your questions in both English and French. I'm happy to respond in both languages throughout the presentation. So just to start with a land acknowledgement. So Kathy, you're right, it is sensitive. I am presenting today from traditional territory of the Mi'kmaq people, so from the city of Halifax in Nova Scotia, which is known as the Mi'kma'ki, which is covered by treaties of peace and friendship and includes all of Nova Scotia, Prince Edward Island, part of New Brunswick, the Gaspé region of Quebec, part of Maine, and southwestern Newfoundland. And so just honored to be presenting from this land today. So in terms of our work at Healthcare Excellence Canada and just situating our appropriate use of antipsychotics work within our strategy, which was developed in 2021, that is ending in 2026, has a real focus on the care of older adults with health and social needs, which is where this work sits in our strategy. And in this space, we're really focused on moving the dials on those really important long-term care indicators that reflect quality of life and those clinical indicators that support improvements in patient safety and quality in the long-term care space. And so the objectives of my presentation is just to set the context, provide the evidence, which there is a plethora of evidence supporting the appropriate use of antipsychotics. The spread and scale journey that HEC has been supporting really since 2014, and some key considerations that we've learned along the way. So in terms of the context and really understanding the problem, in 2013, about 1 in 3 long-term care residents across Canada were taking antipsychotics and medications without a diagnosis of psychosis. And this is all from CI-HI data. So from the Canadian Institute for Health Information. By 2018, the rate had dropped to 1 in 5 residents, which was really positive, and we saw lots of movement across the country and all the provinces and territories with a concerted effort to really take a second look at the appropriate use of antipsychotics in long-term care. And after the challenges of navigating the pandemic, this rate has slowly increased, with latest data showing that 1 in 4 residents is now using potentially an antipsychotic without a diagnosis of psychosis. And over the past decade, HEC has really worked on this quality improvement initiative with several provinces and territories across the country to help support the appropriate use of antipsychotics in long-term care. And so in terms of the evidence, we know that there are clinical indications for antipsychotics in people who have a diagnosis of psychosis. However, in the short term, there are 2 indications for which the use of an antipsychotic would be appropriate, and that is when a resident poses a risk to either to themselves or to others, and also when they have not responded to individualized non-pharmacological interventions, which really should be prioritized as first-line interventions in these cases, because we know that there's lots of negative side effects with using an antipsychotic when it's not appropriate. And we know that they are not indicated for managing the behavioral and psychological systems of dementia. And there's a few examples there. And this is from an algorithm that was developed by l'INES, which is an organization in Quebec that provides health technology assessment support, which provided the evidence for our work in the province of Quebec specifically. And so the approach that we have used to spread and scale this across the country has really been a team approach, which includes the resident, the family, the caregivers, the providers, the team, to really identify through medication reviews who is potentially on an antipsychotic inappropriately, identify those behaviors for which those antipsychotics were prescribed, if possible. It's not always indicated. Identify the appropriate non-pharmacological approaches to addressing and mitigating some of those behaviors, and then putting them into practice, and then constantly monitoring and measuring to ensure that they are really going towards a positive way, and then initiating the deprescribing process while monitoring all along and making those adjustments in a really person-centered care perspective. And there's lots of evidence that supports the use of this strategy. So in terms of our spread and scale work, we started in 2014 with a pan-Canadian collaborative that really supported the spread of this approach. And we worked with about 56 long-term care homes across 7 provinces and 1 territory. And in that first year, we saw a decrease of 54% in the use of antipsychotics. As part of that collaborative work, there was an organization from New Brunswick, which then led to a provincial spread and scale program in that province over 2016 to 2018, which also showed similar results, and then spread to PEI, Newfoundland, and Labrador, and 5 homes who are part of the Seniors Quality Leap Initiative, which is a consortium of homes focused on quality improvement in both Canada and the US. And then in 2017 to 2023, we also spread this approach across the province of Quebec, and it now still lives on as part of their strategy in long-term care, which I'll get to a little bit more specifically. And each time we've adjusted our approach depending on the provincial needs and how they wanted to support the work in each of the provinces based on the resources that they had to really amplify the practice across the province. And then when I look specifically through our experience with Quebec, which was a collaboration between the ministry, so the Ministry of Health and Social Services in the province of Quebec, l'INES and Université Sherbrooke, who are really our evidence and university and research lens to the work, and then all of the long-term care health system partners who participated in this work, so all 24 health authorities who have a long-term care mandate, including patient partner groups, the Alzheimer's Society, and some of the provincial professional organizations. Apologies, I'm tripping because I'm thinking in French and trying to translate on the fly. So the provincial deployment was a phased approach because the initial spread was focused on all publicly funded long-term care homes in the province, of which there's just over about 300. So phase 1 started in April 2017. With 24 long-term care homes, so essentially 1 per health authority who had a long-term care mandate, 1 unit per long-term care home, which represented about 8% of all residents, people living in long-term care. Phase 2 then started in January 2019, where we continued to build on the long-term care homes that were a part of phase 1, increasing to 129 homes across the province. With 325 units and representing about 40% of people living in long-term care. As you can imagine, that phase ended in March 2020. And then we were in the throes of a pandemic, a global pandemic, which really paused this work. While we tried to maintain momentum, it was challenging given the health system priorities and long-term care really focused on the pandemic. And so we relaunched in the fall of 2022 with a broader mandate, and now really looking at all, again, long-term care homes, not just the publicly funded, with the goal of reaching all people living in long-term care. And so the approach to spread and scale was really co-designed with the Ministry of Health and Social Services and our partners really at Université Sherbrooke, who were really the research leads for this work. And so there was a provincial governance structure that was set up to really co-design what this deployment plan would look like, who would be the, as we call, faculty or experts to support the spread and scale, which included researchers and pharmacists and nursing support to really support the practice change. integration into the provincial training infrastructure that already existed, and the research infrastructure, because it was important to also build the evidence around the work that was doing, and also support from the provincial perspective in terms of measurement and data support. And then the implementation support strategies, which is HEC's contribution in terms of supporting the training, building some of that capacity around the process around implementation, taking the lessons learned from our work in the Pan-Canadian Collaborative and the work that was done in Prince Edward Island, Newfoundland, and New Brunswick, and the 5 SQLI homes, and really sharing a lot of those materials and resources that had existed prior, and then also building on the monitoring and clinic and the process measures that were developed previously. And so phase 1 and 2 results are published, and I can share the publications in the chat after the presentation. So phase 1, as you can imagine, it's a very discrete process. And so you need to look at eligibility of residents and then attempt deprescribing, obviously always in conversation with the family and the caregivers and the resident to obtain their consent to embark on this journey. And so in phase 1, the teams, I should say the clinical teams, were able to deprescribe in 50 to 85.5% of residents in which the deprescribing was attempted. And then you'll see the breakdown between, we also calculated decreasing doses and completely stopping doses and reducing dose as a successful deprescription. And in phase 2, we were able to carry over the gains even with a larger number of residents participating in a larger number of homes, which was really positive in terms of the success of the spread initiative that was happening in the province of Quebec. And then we continued to monitor balancing measures, which is always important because we didn't want to see negative impacts on other classes of drugs like benzodiazepines and antidepressants. And we also continued to monitor the behaviors associated with dementia to make sure that there was no negative impacts on the behaviors. We also looked at falls, and we also looked at restraints, which is not on this table, but that was also part of our balancing measures. And so then we relaunched phase 3 in the spring of 2022 with actually a broader mandate to not only look at antipsychotics, but to look at the broader use of medication in long-term care, really with a polypharmacy lens. And so this was the integration of what was formerly known as Opus Ape in Quebec with an initiative that was led out of one of the health authorities in the Quebec City region, Capitale Nationale. It's called PEPS, which is really a personalized approach to medication use specific to long-term care. And so we started in the spring 2022 with a train the trainer model, both for pharmacists, for all of our clinical leads in the province, and for managers, and then relaunched in the fall with an official launch workshop to really set the momentum for this work and reinitiate that momentum, and also continuing looking at deployment plans because we know things had significantly shifted from when we stopped the work, or paused the work, I should say, in March 2020. And then we started data collection processes in November 22. And this time the phase 3 was really launched with that long-term view of really integrating this practice approach into operations. And so while phase 1 and phase 2 was more in a research mode and had a kind of a closed cohort model where everyone entered in at one point, and then all those residents would stay in the program for a year. Now it's an ongoing process that's really built into the operations. And we have done a lot of work to support, which was led by the Ministry of Health and Social Services around the ongoing reporting and ensuring that there's processes in place to look at both clinical and process measures. And so our ongoing key measures that we've been monitoring that are still monitored today as part of this work are in 2 buckets. So we have the medication indicators, which is looking at prescriptions, rate of excessive polypharmacy, regular NPRN use of some of these medications, also the rate of inappropriate use of antipsychotics, which is the link to the CHI indicator on My Health Systems, and then so specific benzodiazepines, antidepressants, and antipsychotics are really the 3 main ones, and then polypharmacy. And in terms of process measures, linking back to the initial part of the presentation where we focused on the approach. So really looking at how the deployment's going across the health system in the province of Quebec, looking at how the integration of team-based discussions, or what we call huddles, or in French it's called a caucus, really around the deprescribing activity and the person-centered care strategies that are implemented to prioritize deprescribing. the number of clinical evaluations and assessments that are completed, the number of person-centered care interventions that are implemented, and non-pharmacological approaches, and then also looking at behaviors and looking at also training and mentorship opportunities for providers, because we know that the process measures are equally important to the medication indicators, and really making sure that there continues to be a thoughtful process to this work, because it's really important that it's person-centered. And so if we look at the current status across the country, this is from my health system, and I accessed it on January 2nd, 2025. So Quebec doesn't report into the CIHA indicator. So just based on the results to date, you can see where they're situated across the health system, and you can see that there's some work to be done still, which it is an improvement journey, and we have a lot of experience knowing that it can work. And so we know that there's a renewed focus on this work, and which is really positive to see. And just in terms of key considerations, I think what was most successful in particular with this specific provincial partnership with the province of Quebec was really a very clear governance and leadership role, with a structure in place with clear responsibilities, and really a mandate by all the healthcare partners to collectively move towards this really important patient safety opportunity. Partnerships across the health system with clear roles and responsibilities, including the Ministry of Health and Social Services, L'Université de Sherbrooke, who was a real strong partner in terms of research and evaluation, both from the clinical side of the work, but also from an implementation perspective. So we have publications in both spaces, and HEC was part of this work as an advisor, given our past history and the appropriate antipsychotics work across the country. Co-designed really provincial specific implementation plan, because it's really important that it respects the context in which the work is happening, and really leveraging all the training and expertise that already exists in that province to really support its implementation. And also we saw this as an opportunity to convene all the provinces and territories together, because we knew it was a common opportunity across all. And sustainability, and really highlighting that it's now been integrated in provincial data infrastructure, alignment with provincial priorities, and integration into long-term care action plans leading into 2026, and I imagine beyond. And so we know that recently there was a report published by a coalition looking at specifically the rates of antipsychotic use in Canada's long-term care homes, and they are rising. So this was a report published by Choosing Wisely, I think just this month. And so just sharing that HEC is continuing the work to support the appropriate use of antipsychotics in long-term care with a new program called Sparking Change. And there's more information on our website. So thank you so much.
Thank you so much. I think you really demonstrated here the value of working with people at very different levels, from sort of government, provincial government, through regional, through even within the home, all the way down to patients and caregivers and families. So really important initiative, and the slide about the differences in different provinces, different jurisdictions is really sort of telling of kind of the variance in which we experience and in which residents experience antipsychotic use. So really interested in learning more as this progresses, particularly as you enter hopefully other provinces. So thank you so much. So most of what we know about medication incidents, about reactions, about harms, comes from reporting. And it's really, I think reporting is the collective aggregated wisdom and experience of the many different prescriptions and administrations of healthcare products, and all are good and sort of less good effects of all these interventions. So I invite our speakers from Health Canada now to tell us more about the mandatory reporting programs.
Thank you so much, Dr. Hamilton. I'll pass it over to my colleague, Marie-Claude Veritus. I am the manager of the Public and Regulatory Affairs Outreach section within the Health Products and Surveillance Epidemiology Bureau. We're quite thrilled to be here today, and Marie-Claude is a regional coordinator for Ontario. So I'll just turn off our camera for now, and we'll start presenting. Thank you so much.
Thank you very much, Joel and Dr. Hamilton for the introduction and Dr. Hamilton for the invitation. Hello, everyone. My name is Marie-Claude Brutus Lopez. I work for Health Canada's post-market surveillance program, the Canada Vigilance Program. I'm really excited to share this update on mandatory reporting of medical device incidents and serious adverse drug reactions with you today. Next slide, please. Before we start, please note that this presentation is copyrighted to ensure content protection and proper attribution when sharing it or reproducing it. Next slide, please. As said, today we'll provide an update on the mandatory reporting aspects of Vanessa's Law, also known as mandatory reporting by hospitals of medical device incidents, MDIs, and serious adverse drug reactions, ADRs. Next slide, please. More precisely, we'll go over the following main points. First, we'll offer an overview of mandatory reporting requirements for hospitals. Then, we'll share a statistical update of hospital reporting over the last 5 years. We'll also share some pointers to improve the quality of reporting. And finally, we'll share a few examples of regulatory actions taken by Health Canada after the coming into force of the mandatory reporting regulations. Next slide, please. So what is mandatory reporting by hospitals? It's a set of regulations requiring hospitals to report serious ADRs and MDIs to Health Canada. The regulations came into force in December 2019, and they stem from Vanessa's Law. Its goal is to increase the quantity and the quality of reports of serious ADRs and MDIs that we receive, thereby expanding the real-world data we use to monitor the safety and effectiveness of therapeutic products. It applies to all Canadian hospitals who must report within 30 days from the date of first documentation within the hospital. As for the products in scope, broadly speaking, mandatory reporting targets drugs, medical devices, and any combination of drug and devices. That said, there are certain exceptions which we visually represent in the next slide. Next slide, please. So here's the mandatory reporting products map, which outlines the health products within and outside the scope of mandatory reporting. As you see, the boxes in red represent the products outside mandatory reporting by hospitals. This is because at the time of drafting of these regulations, there were already existing federal mandatory reporting schemes in place for those products. Next slide, please. Now, moving on to what events are reportable. As we've established, serious ADRs and MDIs. And here are the regulatory definitions of each of these concepts broken down in bullet points for ease of reference. Please note the last bullet point on the left, important medical events. These represent events that may not be immediately life-threatening or result in death or hospitalization, but that might, in the clinician's judgment, jeopardize the patient or require intervention to prevent any of the serious outcomes listed in the serious ADR definition. Some examples include intensive treatment in an emergency department for allergic bronchospasm, blood dyscrasias, convulsions, or severe hypoglycemia. In other words, medical judgment is enough to consider a reaction serious. And of course, if that's the case, hospitals must report it to us. Now that we have explored the basics of mandatory reporting, let's look at some statistics covering the period from December 16, 2019 to December 31st, 2024. Next slide, please. Next slide, please. Thanks. As you can see, this graph shows the number of reports received over the last 5 years. MDI reports are represented in blue, while serious ADRs are shown in purple. We've received over 7,000 MDI reports, for an average of 128 reports per month. On the other hand, we've received over 22,000 serious ADR reports for an average of 367 reports per month. The big peak in April 2020 for MDIs was for face masks with minor problems that nonetheless had the potential to put people at risk. For example, masks fitting poorly, straps breaking, and missing the nasal wire to hold the mask's shape. The peak in March 2023 is due to an influx of older reports submitted in bulk from a single health authority. Otherwise, the reporting of serious ADRs and MDIs has been fairly stable throughout these last 5 years. Please check out the link in the lower right corner of the slide. It'll take you to a statistical summary of serious ADRs and MDIs reported by hospitals and tracked in the Canada Vigilance Database. It's a great resource to dive deeper into the data. Next slide, please. Now let's take a closer look at the impact of mandatory reporting by hospitals. This graph highlights the before and after stats. Again, medical device incidents are in blue and ADR in purple. Now, before we dive into these numbers, just a quick heads up about the MDIs shown in this graph. Along with the mandatory reporting data, we've included reports from the Canadian Medical Devices Sentinel Network, CMDSNet, which was our single source of MDI reports before mandatory reporting regulations came into effect. These CMDSNet reports cover both MDIs, which are serious by definition, and medical device events classified as not serious. Now, since the introduction of mandatory reporting, hospitals submit MDI reports to us independently of the CMDSNet program. However, for consistency, in this graph, we've included on the right-hand side, representing the post-mandatory reporting period, the medical device event reports classified as not serious, still submitted by CMDSNet, so that we show similar types of reports throughout the entire graph. That said, the graph highlights just how much reporting has increased since the regulations came into effect. It is a clear picture of the progress we've made together and of the positive impact that these regulations have had in our ability to conduct health product post-market surveillance through increased availability of real-world data, ultimately contributing to patient safety. Next slide, please. As you can imagine, the quality of the report submitted determines the quality of the data gathered by the Canada Vigilance Program. For example, reporting conflicting dates, using ambiguous acronyms, or aggregating information from multiple patients into a single report are all practices that negatively impact our surveillance work. So let's look at some do's and don'ts for ensuring the quality of reports. Next slide, please. Sometimes the same reaction may happen to multiple patients using the suspected health product. If you encounter this scenario, please submit a separate report for each patient. This is because to carry out our surveillance activities, we work with individual case safety reports. Next slide, please. But what does individual case safety report mean? Essentially, it means one report of a suspected adverse reaction or reactions to one or more health products occurring in a single patient at a specific point in time. So remember, one report per patient, even if you encounter suspected clusters of cases. Next slide, please. Also, please do flag to us if you're submitting a cluster of reports. For example, if you suspect adverse reactions associated with the same product or with the same lot number of a product in several patients, you could let us know in the additional information section of the reporting form. And while you're there, please also include either the organization file numbers, that is the number your hospital assigned to the reports, or the patient identifiers, of the cases constituting the cluster so that we can link the reports in our system. Including this information is very useful for us so that we can realize we are dealing with a cluster of cases, a fact that we could otherwise miss since the reports may be entered in our system by different individuals. Next slide, please. Additionally, when reporting a cluster, it is crucial to include the lot numbers, as the cluster may be, for example, due to a product quality issue affecting the whole lot. Now, let's look at some of the don'ts. Next slide, please. Don't report conflicting dates. The dates within a report are crucial for us to establish a temporal relationship between the use of a health product and an adverse occurrence. Reported dates are also very important for us when trying to establish a cause-effect link between the product and the adverse event. Yet, quite often, we encounter issues with the dates provided in reports. These errors involving dates trigger follow-ups with the reporter and delays in report processing, which impact our ability to inform regulatory action at any given time. So, we strongly encourage you to take a moment to review the dates within reports to make sure they are correct. Let's look at some examples of conflicting dates. Next slide, please. According to the dates in this report, the adverse reaction happened after the reporter submitted the report to us, which doesn't align chronologically, of course. So don't provide a reaction date post-dating the report date. Next slide, please. Similarly, according to the dates in this report, the patient started taking the suspected product 27 days after the reporter submitted the adverse reaction report to us, which suggests an error in the timeline, of course. So don't provide a product start name post-dating the report date. Next slide, please. Lastly, the dates in this report indicate that the reaction started before the patient started taking the suspected drug, which is chronologically inconsistent. So don't provide a product start date post-dating the reaction date. Next slide, please. Moving on to the use of abbreviations. Please don't use ambiguous acronyms or terms in your reports. As you may know, many medical abbreviations and acronyms can have different meanings depending on the clinical setting. And Health Canada must not make assumptions regarding the reported information when coding it during the processing of reports. Therefore, please don't use ambiguous acronyms or terms. Doing so hinders our surveillance activities and triggers the need for us to seek follow-up. For example, this report lists the following medical conditions which lend to interpretation. BC may be interpreted as birth control, breast cancer, bladder cancer, blood culture. Congestion doesn't specify the location, so it could be nasal, liver congestion, sinus congestion, or even cardiovascular. Cramps should be further described as muscle, menstrual, or abdominal. And pain, although frequently reported, can be further detailed as to its type or origin. Now, let's look at a couple of examples of Health Canada regulatory actions since the coming into force of mandatory reporting by hospital. Next slide, please. Before we dive into the examples, let's remind that to carry out our safety surveillance work, we gather safety information from a wide variety of sources, as shown to the left in the picture. So please keep in mind that hospitals are one of these multiple sources that contribute to the pool of safety data available for our detection and management of safety signals. The box on the right lists examples of regulatory actions stemming from our work. Now, let's move on to some examples of label updates triggered by hospital reports. Next slide, please. As you can see from this table, we were able to request label updates, meaning updates to the Canadian product monographs of these drugs to their manufacturers regarding these ADRs. As said, for all these examples, hospital reports triggered these label updates. Now, to round off this presentation, let's summarize some takeaway messages. So hospital reporting has increased since the coming into force of mandatory reporting regulations for hospitals in December 2019. The quality of reports is crucial for Health Canada's health product safety surveillance work. Hospital reporting has increased Health Canada's available pool of safety data to conduct signal detection activities. Hospital reports have contributed and sometimes triggered Health Canada regulatory actions. Now, before we go, here are the next steps we can take to keep things moving and make a real impact. Let's break it down into clear, actionable points. Continue your commitment to reporting. The increase in hospital reporting since the implementation of mandatory reporting regulation demonstrates the dedication to health products and patient safety. Let's sustain this momentum to ensure we are protecting patients effectively. Focus on high-quality reporting. High-quality reports are essential for Health Canada's health product safety surveillance. The higher the quality of reports, the bigger their impact on patient safety. Recognize your impact on safety data. Your contributions are key in identifying potential risks and emerging safety concerns. Be a leader in patient safety. Your reporting saves lives by informing decisions that improve the safety of health products across Canada. Join us in shaping a safer future for all Canadians. Next slide, please. So this concludes my presentation today. I hope it was informative. As my colleague Joël Raymond said, we are available and happy to answer your questions at the end of the session. And you can reach us at this email address for any additional questions or comments. Once again, thank you for listening to us today, and I'll turn it back over to Dr. Hamilton.
Thank you so much. So much to cover there, and it's really encouraging to hear the increased reporting, the outcomes, the changes that Health Canada has been able to make just because of reporting. Certainly, this is how we learn, and I encourage everyone in the audience to continue to contribute. And thanks for that very good advice, I think very sound advice about improving the quality of reports now as well. So I note we're up against 1 o'clock here. A number of you have left questions in the chat box, and I hope we got to most of them. I think all presenters left their contact information, and so feel free to reach out to them. Thanks very much to all our presenters, and a reminder that we do want to hear from everybody. This marks the end of our 9th season here of Med Safety Exchange, our 8th season. Entering our 9th, we want to make the 9th season better. So please give us your advice about what we could do to be more impactful, meaningful to you, the audience, and please contribute. You've heard lots of great stories here from our presenters. Why not be a part of that? Tell us about what's going on in medication safety in your own organization. So with that, please help us by answering the poll, and we shall see you in spring towards the late May of 2025. Please, thank you to all the presenters, and thanks to you, all the audience members.